Check, check. Here we go. Check, check. So I'm going to mute this for now. That's the noise. Wireless 2. Check, check. It is on already, so if you just...
Where's this is the microphone?
This part here. I think this part you can just wear over your ear, actually.
I get it. Right. Oh, good, I can't mess with my glasses. Okay, how's that for sound? Check, check, check. Oh my goodness. This will work. And how do I mute it? I just press and hold?
I think if you just press it once, it should go off.
So I'm on again. Check, check, check. Yep. And the volume, if it's too loud or too quiet?
The volume is also here. So right now we're at 70%.
Yeah. Perfect.
80%, 90%.
Okay. And you can adjust when we first get started.
Absolutely. Yeah.
You'll fine tune, and
what they think.
this microphone works just fine. It's a nice microphone.
So, and then on the second one we want, there we go. Is it showing up on there? Yeah.
Perfect.
So we just have a couple slides at the beginning that'll have a little 2-minute spiel about the RCI.
Okay, just walk.
Then,
tick, tick, tick. And changing slides will be...
we'll figure out the best way to do that.
Do we get a clicker?
Is that the clicker?
Yep.
Yeah, nice. And then this slide you just want at the beginning before the rest
Perfect.
of it, right?
Yes, that's wonderful.
And then I think after this just comes the rest of your train wreck.
Okay, and let's see what it looks like. Mm-hmm. Okay.
Hello?
Yes, you're on. Hello.
Oh, hi.
I'm testing the microphone.
Yes, there you are. We see you. I don't see the audience, I only see you. Oh, there you go.
Yeah, so
Thank you.
whenever someone presses
Okay.
the mic like that, it'll
Okay. Is it possible to have your camera on the audience itself so that I can see how they're responding?
I don't think so. But let me see if I can. No, it does not give me the option to show a camera in another room.
No. Do you have the ability to record this talk?
It is going to be recorded, yeah.
Wonderful.
It just automatically records.
That's great.
So the one thing about these audience mics is that if someone has theirs on, no one else can use theirs.
Right.
So they'll have to turn theirs off before another person can answer a question.
Good.
So if that does come up a few times, you might just have to remind people to turn off
Right.
their
Turn off your mic when you're not speaking. Okay, good.
Otherwise,
If I'm using the pointer to point at my slide, they're not going to be able to see where I'm pointing in the other room, will they?
sorry.
If I'm using my pointer to point in this room, they won't be able to see that in the other room, so I'm going to have to
No,
describe what I'm talking about. On this slide, third point down, I'm talking about this.
I think you're right. Yes. So not the best venue for that reason.
So,
Trevor, I haven't seen you for a long time, Trevor.
I've got a microphone on.
Nice to see you, man.
Hello.
Nice to see you. It's good to see you still wearing mama's
Hello,
sweater.
Matthew. Again. I'm going to
also I went in. Just turn off the mic thing. Dear. It's more comfortable. We don't have pretty good. From the last better picture of that. What you're listening. We should get a book club. You did? Where did Kale go? Maybe the other room. They managed to get into that room. Oh, they did? Okay, let's sit here. Picture the tree there. So they just want to have that seat. What time to come here? Oh, look at you. You feel so embarrassed. Look at that discipline. I'll just let them. Good point. But my phone was on silent. Midnight we did.
Thursday's at Cook in the kitchen.
Oh, you're
There's a kitchen.
you really cook? You're the cook? Wow. Where's that?
So this Arnold. It's next to the church.
We haven't seen you.
I'm a pretty good cook. Although it's a certain style of cooking.
Like,
Kind of not too.
like big pot of rice or big pot of.
Yeah, okay, not too spicy, not too. Make it too spicy. Like,
Good. You got it. Did you get this?
No, not yet.
No? Okay, I'll grab you. It's outside the door. Yeah. Not good.
It's got ice cream. This is spinach. Oh, hi, Rita.
Hello, how you doing? There's a lot of people here. It's
Yeah.
everywhere. It's in the gourds and everywhere. Gourd, Sandpan, everywhere.
Yeah.
Yeah.
Yeah, Jennifer's here.
I didn't see Jennifer yet.
Where are you working now, Ruby? Not home. Oh, okay. Hello. Hi. Oh, you accepted new building? Yeah. February next year? Oh, okay.
don't, today is May the 9th. And then May the 10th is Friday, and then May the 11th. I didn't know that. I work 3 to 11.
Yeah.
3?
I remember when there was
No, I don't think so. Okay, I have to ask my
one
husband.
makes us called bedroom
It's some of our friends.
and mix it with olive oil.
Oh,
So that it was spreadable.
so anyways, no. I asked her. It's even short.
To be entirely honest, I just butter, but I think that people who are comfortable with actually it's to be saturated. Half and half, it's spreading more in olive oil, but in that case,
We'll go far side. Or we did that last second or third? Oh, second. We can do the second. Oh, yeah.
Deborah and Rachel.
But me, you coming tonight?
Yeah.
Yes, and Sam Pam. And Sam Pam. Where are you from? The Gorge, yeah, you girls are all right.
I wasn't today.
We all used to start at the Gorge. We all used to work at the Gorge.
Yeah. You know what? You're right. They all start there. And they disappear.
Yeah. I don't know what you're talking about. Sam Pam, we get them and then they go somewhere else. Huh? I like working at the Gorge. Yeah, I just go to 2 places. But you know what? When I tried to go back to the Gorge a couple of years ago, she said she had 20 people. And I said they were criminal.
I'll sit here.
Yeah.
Well, that's for sure.
And you got lots of staff then.
You're all around.
Yeah, what about cash outs?
They come and go.
They come and go?
Yeah.
I take it essentially. Yes. Where do you work?
I work at Brackenhurst.
I did my practical training 3 years ago. Did you? Must have. I worked for a weekend. And I also worked for
it's not because they're they do buy it, but they buy it as a share. So you don't find out what what's going to show up. So
Work it out.
Hello? Hi, can everyone hear me? Hello. Hello, welcome. Oops. Hi, good evening. Welcome. How's the dinner? Yeah? Woo! It smells really good. Hi, good evening. My name is Megan Schultz. And welcome everyone to the RCI Learning Series lecture on the Dementia Trajectory. It's a little bit of a mouthful to say. I'm Megan Schultz, and I've recently joined the RCI team as a program coordinator. So it's great to meet you all and to put faces to names. Some of you are becoming more and more familiar as time goes on as well. I am a registered nurse. I've worked for the last 4 years in acute care, and some of you will probably start to see me more as time goes on. Before I introduce our speaker for the evening, I'd like to tell you a little bit about the RCI. The Residential Care Initiative is a program of the Victoria and South Island Divisions of Family Practice, and it launched in 2015. The RCI is focused on improving medical care for residents in our regions through supporting physicians to meet the RCI best practices in long-term care. And there we go. And these are the best care practices. As well as facilitating collaborative system change alongside physicians, care home staff and leaders, and island health. This learning series is one of the ways we support the local long-term care community. RCI coordinators such as myself and Annabeth and Cherie, who's not here tonight, are available to provide personalized support to care home teams. If you'd like to learn more, or if you're a physician and would like to sign up, come and speak to any one of us on the RCI team, including Emily, who's over there in the black dress. Now, I'm very pleased to introduce our speaker, Dr. Trevor Janz. Dr. Janz is a family doctor who works in Nelson, BC, and is also the medical director of long-term care for Interior Health East. He is a house physician at 2 long-term care facilities, caring for 130 elderly residents with dementia or other complex medical conditions in the last years of their lives. He works regionally and provincially on a number of initiatives in hospice and palliative care, advanced care planning for end of life, management of severe behavioral challenges in dementia, and reduction of medications for frail seniors. Recognized as an active advocate of improved quality of life for frail seniors and good end-of-life care, he has often been described as offering care with heart. We hear he has been known to drop to his knees in order to have an eye-to-eye conversation with a resident. Dr. Janz is also the author of the Dementia Roadmap for Families, which you each should hopefully have a copy of. If not, there are some more just outside the door to the right. Now, please join me in welcoming Dr. Janz. Check, check.
Apologies for the technical difficulties. It's guaranteed. The more technology you have, the more likely it is that at least one thing is going to go wrong. When I prepare talks and present, I bring enough stuff with me that I could present if there was no electricity and we had to do it by candle. If we had to do it by candlelight, I could still give the talk. Yeah. So, I'm Dr. Trevor Janz. You guys can hear me. I don't have to crouch to the mic.
So let's get this one.
I need.
Just want to try again, Dr. Janz. I think it should work now. Okay, I'll put this one in. Yeah.
I'll let you play.
There we go. It should be ready to go now. And then we'll go on. So just on the try.
Test, test, test.
And just down here. Yeah, looks like it's working.
Check, check, check. Oh,
Right.
wow, we're rocking. Okay, room 160. Can you guys hear me? Somebody touch your microphone in room 160, and you'll come on the screen, and you can tell me if you can hear us over there or not. Can somebody in room 160 hear me? Nobody answering. You're not waking up?
Yes.
I don't know if they can hear us or not. Are they coming? Hello? Is someone? Okay, you're there. Can you hear us all right? If you touch your microphone, we'll be able to see you. Just hold your hand up if you can hear me.
Hello. We can hear you.
Yes, thank you.
Yes, we can hear you.
All right. We're rocking. How's the sound back there? Can you guys hear me all right? Yeah, I like this microphone. It's lovely. So I'm a GP from Nelson. I never had I didn't have an office after my first 10 years in practice. I did long-term care and emergency medicine. I worked just in the emergency department. And when I first came to Nelson, they had a Willow Haven hospital about 10 minutes out of town, 6 miles out of town, that always had a house doctor, because when you live in a small town and something is more than 5 minutes away, it's just too far to drive, and they couldn't possibly go all the way out there to see those patients. So I became the house physician at Willow Haven Hospital, an old building for 80 residents, and was inducted into long-term care and had a wonderful director of care who taught me a great deal and figured out that I actually love this. And I've been doing it ever since, and that's been 25, 30 years. I just stopped being an emerge doc 2 years ago, and I don't really feel like a real doctor now that I'm not an emerge doc anymore. But I've got lots of jobs with Interior Health. I'm a medical director. They pay me 1 day a week to talk to people about improving care for seniors. It's a dream job. My job the job description is improve quality of life for frail seniors. Who wouldn't want to do that job? Yeah. Actually. So talking to you guys, and I love it that there are a number of different disciplines in the room. I'm not just talking to doctors, I'm talking to nurses and care aides, LPNs. I hear we've got social workers, rec therapy. Do we have dietitians? Yeah. Have we got rec therapists? Maybe in the other room. Not sure. I'm delighted. Residential care is a team sport. When we function together as a team, and the family come in the door, and they're received by all of us together, and they see that together we collectively have got their loved one. When a wife has been caring for her husband with dementia for years and years, and she's in an advanced state of burnout, she is so deeply engaged in making sure that everything works well in his life that she can't trust us. We have to prove to her that we actually understand her husband and can meet his needs and can care for her, because no one will ever be able to do it as well as her. And she's been micromanaging every detail of his life for so long that she doesn't know how not to do this. And until we prove that we've got the ball, she doesn't trust us yet. I talk about a trust bank account, and we have to front load the bank account. We have to show up right at the start and really get to know dad, husband, as quickly as possible, and get to know his needs and show her that we can take good care of her dad, her husband. Yeah. And if we've got that trust bank account, if we build that connection, as a house physician, I don't have any relationship with this family. I'm starting from zero. So I have to, right from the very first visit, build that rapport and trust and caring, that resident-centered focus that says, what works best for your loved one? What does he need to make this work for him? This is a huge transition. He's leaving his home. He's leaving you. You're not going to be in the bed beside him. He's going to be lost. This is going to be a pretty traumatic event for him. How can we do this together to make this work? And when we build that connection right from the start and front load the bank account, I'm going to show up for you. I'm paying attention. I'm making notes. I'm following up on what I do. I make sure that I carry out the steps that I promised that I was going to. When we as a team do that, then we get the trust. And then when something inevitably goes wrong, a carrier leaves him on the toilet for 2 hours because she put him on the toilet and then went and got called to something else and forgot that he was there. The inevitable accidents that occur, we've got some trust, and the family can we can work with them. It's a lot easier if we've got that trust there first. So long-term care has changed a whole bunch in the 30 years that I've been doing this. How many of you have been in residential care for more than 10 years? How many of you have been in for more than 15? More than 20? More than okay. So there's a lot of collective wisdom in this room. When I started doing long-term care, there were men who brought their cars to the nursing home. They'd go and play some golf, and then go into town and have a beer, and then they'd come back to the nursing home. Yeah, those were residents in those days. Yeah, things have changed a whole bunch. Our length of stay is getting shorter and shorter. Residents are coming in sicker and sicker. They're way more complicated. Yeah. The provincial government, for physicians, you might not know this, in my medical director role, I know about beds per 1,000. It turns out that the government when I started, we had about 105 long-term care beds for every 1,000 people over the age of 75. And then the government decided that they couldn't afford that, and that people were getting older. The baby boomer bulge was coming, and we needed to bring people in later and not keep them in long-term care for as long because it was too expensive. And they reduced the beds to 93 beds. That was about 7 years ago. And just over this last 2 years, they've been reducing our residential care beds to 84 beds per 1,000 people over the age of 75. And if you notice that it's harder to get into residential care, or you're waiting longer to get a bed, it's because they want them to come in later and not die sooner, but they'd like, instead of spending 2 years in long-term care, they'd like them to spend a shorter time. And our average length of stay has gone down to about 14, somewhere between 12 and 14 months, depending on where you live. So from the day you come in the door, statistically, an average person coming in the door is going to die within the next 12 months. I was working really hard 2 years ago. I couldn't figure out what was going on, why I was working so hard. So I actually did my own statistics. And to my surprise, I found that 40% of the residents that I admit die within 6 months of coming in the door. 2 out of 5 are going to be gone in 6 months. 25% die within 2 months of coming in the door. They're really in the last months of their life. Microphone.
I'm not sure from how you're saying that. Are you perceiving that as negative, or are you just describing it?
I think, so when you ask a question, I'm delighted, but if you turn your microphone on, the other room can hear it. I think that's good. No, that's not negative at all. I'm shocked. I'm describing. Yeah. So what it means for us is that we've really got to wake up and start realizing that we are a palliative service. This is palliative care. This isn't long-term care. This is short-term care. Yeah.
No term.
We've got to wake up. When that resident comes in the door, we don't have years and years to get to know them. We need to get on this. Pain and symptom management, the social history, the background, we need to receive these families and their loved one lovingly and get on the ball. We need to do all that work right at the front end quickly because we might not have a lot of time. Yeah. And social work, the role of social workers. Thank you, social workers. I functioned without a social worker for my first 20 years, and I've only had a social worker for 5 years. You guys are invaluable for that first 2 or 3 months as they're coming in and the family's on the roof and we have to convince them that it's actually okay. They're going through that huge grieving process of putting dad in the facility. There's a huge amount of work there. And then there's the 3 months or 6 months as mom or dad is dying, and there's a huge amount of work there too. And if they stay for 4 years and we do 2 months at the beginning and 3 months of hard at the end and a whole bunch of smooth sailing with not much work to do for 3 years, that's easy. But that doesn't happen anymore. If they're dying within 6 months, we've just got you in the door and settled, and then we're already having the dying process, the dying conversation. So we really need to do this work faster. Yeah. In my 92-bed facility, I did 58 deaths last year. Yeah. That's 2/3 of the building that go. We had units where 4 residents died in a month. These are 18-bed neighborhoods, and 4 out of 18 residents died over a 2-month period. I don't know if you guys noticed, but November, December, January, February is the clump. Yeah. I think people look around, the days are shorter, it's snowing, it's cold. Have I got enough gas in my tank to make it through till next spring? Nah, I'm done. The coldest, shortest days of the year, the longest nights, the cold. They just check out, they stop eating and drinking, and they go. Yeah, we did that, cleaning house. So the province has recognized that we're a palliative service. I've got a medical director colleague, Dr. Diana Peters in Vernon, who introduces to families the first time she meets them that we are end-of-life care homes. We're not a nursing home. We're not a residential care facility. We are an end-of-life care home. Puts the end of life right in the name. This is the elephant in the room in residential care. Hands up those of you who have ever said the dying word, the D word, to a family. Oh, look at that. Wow. Doctors. Hands up those of you who have ever said the dying word to a family. The dying word D. Have you said dying? Your mother may be dying. Yeah.
I wonder if you could speak up a little bit more.
Okay. Okay. Where's my techie? Is it the position of the microphone? Do we turn it up or change the microphone? Yeah. Thank you for. Yeah. I'm hoping that room 160 can hear us as well. Okay, how's that? Is that any better? Is it the position of the microphone? Let's try. Okay, I'm going to check with you. So health authorities and the provincial government are now promoting a palliative approach. In interior health, we're following Fraser and Fraser Health with a palliative approach in long-term care. We call it the Palm Project, the image of holding the residents in the palm of our hands. The palliative approach emphasizes comfort rather than cure. Are there any residents in your building who are going to cure? Are they going to get better and go home? No. Are there any diseases that we're going to prevent or take away? No. So the preventative medications, the statins, doctors, there's not a single resident in my 130 beds that's on a statin anymore. Yeah. 40% of residents in long-term care are on a statin. If you've had a heart attack and they put you on a statin, you need to take statins every day for 5 years. 83 people need to take a statin for 5 years for one person not to have another heart attack. If you've had a stroke and we put you on a statin to prevent another stroke, 182 people have to take a statin for 5 years to prevent another stroke. I explain that number to families and explain that it causes liver inflammation and muscle aches and pains, and many residents feel quite unwell while they're taking it, and they all stop. Yeah, it's easy. None of my residents, well, that's not true. I was going to say none of my residents will live another 5 years. The old and frail ones, they're not going to live 5 years. And even if they do, it would take 182 of them living for 5 years to prevent one heart attack or stroke. And by the time they get to my building and they're frail and moderately demented, and they may or may not recognize a family member, and they're fecally incontinent and a mechanical lift transfer, I and the family are starting to think that a heart attack, quietly in the middle of the night, and they wake up in heaven, is actually a really nice way to go. Compared to the alternative of late dementia and choking and feeding difficulties, well, I'll take the heart attack, thank you very much. And having those conversations with families can often simplify and clarify our goals of care. How's the sound? Can you hear me any better? Better, thank you. So, palliative approach, comfort, more important than cure. Early recognition. We need to recognize, as they're coming in the door, how palliative is this person? Are they going to live for months, or are they going to live for years? And if they're going to live for years, we've got some time. But if they're going to live for months, we better get going on having these conversations. So early recognition. If you've got congestive heart failure, 80% of our patients have dementia. About 15 or 20% are medically frail. They may also have some compromise. Medically frail residents are the ones who die the most quickly. They're the ones that come in and die in 3 to 6 months. Dementia residents, they come in the middle stage of dementia that you're going to hear about this evening, and they've got a year or two. But the medically frail patients come in the door quite sick, quite old, and actively dying, and we need to get going on those ones. If you come in with class 4 congestive heart failure, that's shortness of breath, Not just with exertion, you're short of breath going to the bathroom, but you're short of breath just sitting in your chair. You're on oxygen, you may be on oxygen, you're on a number of medications. We've optimized your medications and you've still got symptoms even at rest. Yeah, your life expectancy is worse than that of cancer. You've got a 50% a year mortality rate. Yeah. And stage COPD, the same story. So early recognition, notice who's not going to last, and jumping on early. Early goals of care conversations with families. What do you value? What's important to you? How much would you like us to use the hospital? By the way, we're going to talk lots about trying not to use the hospital, and avoiding unnecessary emergency transfers, and avoiding the potentially burdensome medical interventions. If your mom has a spell, if she's got vascular dementia and she's periodically having these unresponsive episodes, I don't think that going to the emergency department and waiting in the emergency department for 9 hours on a stretcher and then having a CT scan and blood work and a septic workup and intravenous antibiotics is a good idea. I'd like not to go to the emergency department. I'd like to treat your mom right here. We'll have that conversation with them early. There are a whole bunch of things that we could do for these frail elderly people. Most of them are not going to make much difference, and they're going to vastly reduce their quality of life in the last months or years that they've got left. And I try to transfer as little as possible. We're going to talk more about that. And the essence of palliative care, which is impeccable pain and symptom management. We need to do a really good job of focusing on their comfort. My mantra is pain, bowels, sleep, mood. And we'll talk about that more. But untreated pain, there is so much unnecessary suffering in long-term care because we're not recognizing their pain, we're not treating it adequately, and we're not advocating with the doctors when our pain medications are not strong enough to start using opioids. I'm not sure how comfortable or not comfortable you guys are about using opiates, but about 35% of the residents in my building are on opiates. I don't use any anti-inflammatories because I've just had bad experiences with GI bleeds. So if you're on your maximum dose of 4 or at the most 5 grams of Tylenol in a day and you still have pain, I go to opiates early and often. And I think that if this was my mother, I wouldn't want her to hurt. You know, the most painful thing that we do in long-term care for residents who are old and stiff, they've got rigidity, they're barely moving, and they don't roll over in their beds at night, is to get them up in the morning and change them and dress them and get them to the breakfast table so that they can get their morning pain medication. And we do the most painful thing when they haven't had any medication all night long that hurts them the most, and the caregivers know that it's hurting them. The care aides are hurting them every day, rolling them, turning them, trying to get their arms into the shirt, and they're moaning and groaning. This is trauma for the resident, but it's also trauma for the caregivers. They're hurting people every day, and we need to treat this. Long-acting pain medication given the night before usually wears off, and the lowest dose of MS-LON, the long-acting morphine, is 10 milligrams twice a day, and my tiny little 80-pound birds, 20 milligrams of morphine a day would kill them. So I can't use the long-acting medications. I can occasionally use a Butrans patch. The Butrans patch, buprenorphine, 10 micrograms per hour, is about the same as 5 or 10 milligrams of morphine a day. They're relatively cheap. It's $10 a patch. They go on for a week. Butrans 10, 15, and 20. And occasionally when I'm having trouble getting the oral medication in, a Butrans patch will work for them. Mostly I'm using morphine and oxycodone. Oxycodone, morphine 2.5 or 5. Oxycodone 2.5 or 5. Oxycodone is Percocet or Talwin. On the street, this is the worst possible drug for physicians to use. It is so addictive. It's a terrible drug for people out on the street in the community. But in residential care, I like it. Because the reason it's so addictive is that it's slightly euphoric. Makes you feel kind of good. And if I can give my residents something that makes them feel a little bit better, I like that. And I'm using tiny doses. Oxycodone 2.5 twice or 3 times a day. If you're not tolerating, if the Tylenol's not enough, use opiates. Use morphine if you don't like the oxycodone, but try the oxycodone. And it's supposed to only last 4 hours in an oral dose. But my experience is that when you're old and frail and your metabolism is slowed down, I can get away with 2 or 3 times a day dosing. Breakfast, lunch, and supper. Or breakfast in the middle of the afternoon and bedtime, if they've got bedtime pain. Try it and see. Tiny doses. Start low, go slow. Yeah. So palliative care, comfort over cure, early identification, early conversations with family about goals of care and what to expect, what's coming. Avoiding the emergency department. Impeccable pain and symptom control. We need to ask, do you think he's having pain? At every conference, is he having pain? When I'm talking to the curates, do you think he's having pain? When I'm talking to the family, do you think we're doing a good job of controlling the pain? What we're doing is looking for the sweet spot. Not enough drugs and pain with care. Too much drugs, constipated, falling, and sleepy. Sweet spot, right in the middle. And that moves over time. I'm constantly looking for the sweet spot. I ask the nurses, what do you think? Are we in the right place? Is it too much? Is it too little? Should I turn it up? Should I turn it down? How's their pain first thing in the morning? How's their pain with care? How are they doing in the middle of the day once they're in a chair and comfortable? Are they over-sedated? Let's try and find the sweet spot, titrate to the right dose. Yeah. Okay. When I say the word palliative to families, they freak. In our culture, palliative means actively dying. I'd like palliative to mean let's focus on comfort. But I do a better job. I have more success with families when I talk about comfort care. So use comfort care if you want. But if you want them to accept that comfort care approach, we need to start talking to them early. And we need to explain to them that dementia is actually a life-limiting illness. Dementia is a terminal diagnosis. They think, oh, my dad's got Alzheimer's. He's going to die of old age with his Alzheimer's. No. Dementia is a terminal illness. Alzheimer's dementia carries an average 7-year lifespan from diagnosis to death. The range is about 6 to about 13 years from diagnosis to when you die, and there's a very predictable trajectory. Very predictable. We'll show you that trajectory right up there in just a minute. There are recognizable stages, and I'm going to go back. Take that off for just... Oh, no, I don't want that slide. I will stay with this one. I want to talk about different flavors of dementia just for a minute. Alzheimer's dementia, slow, steady decline, loss of short-term memory, loss of orientation to time, and then to place, and eventually to person. I don't know what day it is or whether it's morning or afternoon. I know I'm in the care facility, but a little later on, I don't know I'm in a care facility, and I don't know I'm in Nelson anymore. And last, I don't recognize friends. And at the very end, I don't recognize my loved ones. I don't recognize my family members. Next most common dementia is vascular dementia. Vascular dementia doesn't go like this. It goes like this. With these vascular events. Also called multi-infarct dementia. When you look at their CT scan, when you look at somebody with Alzheimer's disease, their whole brain has shrunk. There's a whole bunch of empty space in there as they've lost more and more neurons. When you look at somebody with multi-infarct dementia, it used to be called Biswanger's disease. There are a whole bunch of spots, tiny little places, often hundreds of them, where a tiny blood vessel has gotten hardened and blocked by a clot, and that little area of brain has lost its oxygen and died. And when that happened, the resident was clumsy in their right arm for a day or two, or they had a fainting spell in the dining room, or they were less responsive, or they were leaning like this in their chair, or they were falling, or they couldn't form words, or they were really drowsy, or they didn't recognize family for a while, or were talking gibberish, and then they got better again, or we didn't notice anything at all. And that's one of the hallmarks of vascular dementia, is that you're constantly fluctuating. You have these spells. You faint in the dining room, but your blood pressure's fine, and your heart rate's fine. Why did you faint? Or you stop eating for a day or two. I've got a Carl. I've told his family that he's dying 4 different times. I've been wrong every single time. He's got severe vascular dementia, and he stops eating and drinking and is unresponsive in his bed. I think, oh man, that's it. And 3 days later, The family are all sitting bedside watch. And then he wakes up and says, "Where's breakfast?" He did this 2 weeks ago, and he was down for 5 days. And I said to the family, "Okay, is this life number 9 of 9 lives? What do you think?" He said, "Yeah, I think it's done." Day 5, he got up and asked us for breakfast. He's still with us. This has been a year like this, and that's vascular dementia. Sudden change, decreased level of consciousness, slurred speech, poor balance, confused, that kind of stuff, and then okay again. And you just can't predict. You could go like this for a long time, or you could die tomorrow. So what else about vascular dementia? Okay, so Alzheimer's disease, you walk till your dying day. You're just the Energizer Bunny for many of them. Vascular dementia, you lose your walking and your balance and you fall. Or you may lose your speech. Or you may lose your swallowing. Or you may be unlucky and lose all 3. But with vascular dementia, you're not going to walk. You're sooner or later, you're going to lose your walking. Some are going to lose their speech. And many are going to have swallowing difficulties from relatively early on. So those are the pieces to watch for. Gait and balance issues, the stepwise progression. They lose their insight and judgment. They fall. And you think that they remember the last 16 times that they fell trying to stand up from their wheelchair? No. They try and stand up again, and they fall over and over again. They have no insight or judgment about things, so very poor judgment. And there's often depression. After a major stroke, about 60% of people who've had a major stroke will have depression afterwards, and they're certainly prone to that. And I would too if I had a major stroke and I couldn't walk or talk this is a huge life-changing event. So Lewy body, or Parkinson's dementia. How are we doing for time? I better get moving, Trevor. So Parkinson's dementia, you know the features of Parkinson's, the mask-like face, the slow movement, the rigidity, the tremor, the festinating gait where they shuffle and tip over forwards and fall. They often have hallucinations, visual hallucinations. They see animals, they see all kinds of stuff, they see children. Marked fluctuations in their ability. They have on and off symptoms, motor symptoms. When they've taken their medication, they can move freely. Dopamine is the neurotransmitter that allows us to move smoothly and gracefully. And in Parkinson's disease, you lose the ability to produce dopamine in the motor cortex, down at the bottom, the basal ganglia. So they can't move, and we give them Symmetrol, levodopa, to try and replace that. That was my phone. Sorry. Stop. We give them levodopa. Schizophrenia is a disease of too much dopamine, and we give them dopamine blockers. So with Parkinson's disease, you don't have enough dopamine, and we give you a whole bunch of levodopa. And if we give you too much, you have really vivid dreams that you're absolutely convinced are real, and very disturbed sleep. And you can't tell the difference between reality and your dream life. You get a form of schizophrenia. Schizophrenics, we give them anti-dopamine agents. All of the antipsychotics that we also use in residential care block dopamine. And if we give you too much of that, we give you Parkinson's. And patients on too much risperidone are leaning in their chair, they're drowsy, they're drooling, they can't swallow, they shuffle, they fall. So Parkinson's at this end, not enough dopamine. Schizophrenia at this end, too much dopamine. Give your schizophrenics anti-dopamine agents, we give them Parkinson's disease. Give your Parkinson's, old and frail, they tolerate the levodopa less and less. It works less and less, so we give them bigger and bigger doses, and they get the symptoms of schizophrenia, the delusions. Yeah. Last dementia, frontotemporal dementia. Frontotemporal dementia, usually younger, oftentimes more rapidly progressive, and not like the other dementias. It doesn't behave the way normal dementia does. They have good short-term memory. They're often really sharp. I've got a lady in my special dementia unit for the last 3 years who's got late frontotemporal dementia, and she can still tell me her accountant's phone number and do math. Those abilities are well preserved. But there are changes in the frontal cortex. When you do a CT scan on these guys, their frontal cortex is atrophied, it's shrunk. And there are different flavors. One variant, the most common one, is the personality type, where there's a significant change in their behavior and they seem to lose all their filters. They do and say things that are socially just so atrocious. I had one fellow who had a lovely man in his 50s working at the Walmart, steady job, no troubles. and he started shoplifting. And they couldn't figure out what was going on, and they fired him. And then he stole a car. And they asked him, why did you steal a car? I don't know. Did you need a car? No, I got a car of my own. They put him in prison. And it wasn't until he was in prison that they figured out that he actually had frontotemporal dementia. And he's in my dementia unit now. Nice guy, but watch your car. Yeah. So they have disinhibited behaviors. So anything that has to do with a desire, you and I will filter, but they don't filter that. So drinking, gambling, money, sex, socially inappropriate behaviors, all those things can go. Think about getting really drunk at the office party and telling somebody, you just love them so much. or telling the boss what a total jerk he is. That's frontotemporal dementia. This is a really dumb idea for me to say this, but I'm going to say it anyway. Yeah. So that's the behavior one. There's another one that's speech and language. They lose their speech and language, and they can think and they can feel and they can do anything they want, but they can't do language. They can't read, they can't write. When you say it, they can't understand you. They can't speak in ways that they've got the ideas in their head, but they can't put them in words and give them to you. And that's the language variant. There's another variant that's just about apathy. They just sit on the couch. For years, they're sitting watching a hockey game, and their wife says, Why are you watching hockey? And she turns off the TV, and he's still just sitting in the living room. They weren't even watching the hockey. They're just doing nothing, and that's the apathy variant. Yeah. They tend to go more quickly. I think I've not ever been able to corroborate this in the books, but my sense is that they go faster than Alzheimer's, 3 or 4 or 5 years, and it goes quickly. So for each of these dementias, now I'm going to show you this slide up here. For each of these dementias, the timetable may vary a little bit, but the course is the same. The path, the trajectory. So I'm going to start you at the bottom left here. You've got this in your package. I'm going to start you at the bottom left with a baby and go all the way up to a teen and adulthood, right up here at the very top. And then I'm going to work my way down the right-hand side through early dementia, middle dementia, late dementia, and actively dying. And in no way am I being disrespectful of these dear souls. People hear this and they say, you're comparing my father to a baby, and that's so totally inappropriate. With the deepest respect for these dear, dear souls, what's happening is that they're gradually losing their ability. Their physical brain is no longer to do all the things that they need it to do, and they're losing these basic activities of daily living. And the fascinating thing is that in exactly the same order that a baby learns these things from baby to adulthood, we go through exactly that sequence backwards from early dementia down to late dementia. You'll see the parallels as we go along. So, I've got to get moving here. Babies when their babies are brand new, they're born, they don't know how to swallow, they don't know how to latch, mom's milk hasn't come in, they spend the first 3 days trying to figure out how to latch that baby onto that boob and get the baby sucking. And after 3 days, mostly, they figured it out. There's a lot of moaning and wailing and gnashing of teeth in that 3 days, having been through it a few times. But they figure out how to swallow, and they spend the first 3 months of their life sleeping and eating and sleeping, and that's all they do. And then they start to roll over, and then they start to sit up. And at about 6 months, they can sit up and look at the world, and they notice that there's a world out there. Yeah. And then they start being fed with a spoon, and they start crawling. And then around a year, they're starting to pull up on things. They can't walk, but they can pull up and stand. And then they start walking at a year. They start holding finger foods, and everything that they can reach with their hand goes straight into their mouth. Yeah, we'll come back to that with later dementia. And then eventually they learn to use a spoon and then a fork. And as a preschool child, they're talking. They start with a word or two at a time, and then more words and then sentences. And then they get to the stage where they can actually read, and we'll get to that later, full sentences. Toilet training, they learn how to have a bowel movement in the potty, but they're still wet at night, and then they're mostly dry at night, and then they're fully toilet trained, and they can clean themselves up, and they learn to dress and do their hair and their teeth, and now we're in school, and we learn our letters, and we learn to read, and then we learn to comprehend, and we do math and manage money, And wonderful. Age 10, they're finally old enough that we can leave them unsupervised. They can come home from school and be home by themselves for an hour until mom or dad gets home from work. It's a hugely liberating moment. Yeah. We're going to come back to this in just a minute with dementia, because for caregivers, being able to leave your loved one unsupervised, we'll come back to it. So as a teenager, you learn to do a whole bunch of things. You learn to manage money, get a job. You learn to find your way around by yourself. You learn to drive a car. You put food on the table, all that stuff. So these are instrumental activities of daily living. And the simple definition of instrumental activity of daily living is all the things that you need to know how to do so you can leave mom and dad's house and move out and get a place of your own. Yeah, all the things that you need to be able to do to manage independently in the world. And then you're an adult and you're good. But as you develop dementia, you start losing all of those things. The guy who is really good at fixing cars gets it apart, but he can't put it back together again. He can't figure out how to do it. The woman who's done beautiful knitting. My mother knit the sweater. I lost my mom when she was 66 and I was 39. But before she left, she knit me a whole bunch of sweaters, and I wear a sweater of my mother's every time I talk. So this is in memory of my mom. Thank you, Mom. Yeah. And my mother-in-law, who also knit beautiful Fair Isle sweaters, complex patterns, is developing dementia, and she can't figure out the patterns anymore. She can't even do a simple sweater with no patterns. She looks at the needles, she gets frustrated, and she puts them to the side. And when people with early dementia can't do their hobby anymore, and it makes them mad, and they don't want to be interested in it anymore, that's the first sign of dementia. Yeah. Other markers for early dementia, are depression. You figure out that you're not the man that you used to be, and you know that it's not going to get better, it's going to get worse. Even if you don't know this consciously, at some level you say, oh shit, I'm in trouble. And that's a depressing thing. It's people 2 years, late onset depression in somebody who's never been depressed before, 2 years later will have the diagnosis of dementia. Or they get a post-op delirium. Post-op delirium is a marker. If you've had a post-op delirium, it means that your cognitive reserve is about this much, and it's getting thinner. Yeah. So you lose all your instrumental activities of daily living, and that's early dementia. And the simple question about how far you are along in your early dementia is, how long can you be left unsupervised? And in the early stages, wife can go out with the girls all day and come back and cook you some supper and you're fine. And in the later stages, she can go out for an hour to get groceries. But she's in a hurry, she's nervous, getting back at the end of the hour because you're going to be pacing and anxious and trying to find her all over the house. And you'll go out of the house and you might wander away and you might not be able to find the house again. And in the late stages, she can't leave you for a minute, and she's not sleeping at night. She's up 2 and 3 times a night making sure you've not gone out the front door. And she's so burned out and sleep deprived and exhausted by all of this. Yeah. So ability, as soon as you can't be unsupervised for even a minute, we've officially transitioned from early dementia into middle dementia. Early dementia is all about losing your instrumental activities of daily living. Middle dementia is all about losing your basic activities of daily living. And at the start of middle dementia, shortly before you come to residential care, you're still able to do your hair and your teeth. With some support, you're able to dress yourself. You're still continent of bowel and bladder. You can talk. You can tell us what you need, hungry, thirsty, wet, cold, tired. And as you go through middle dementia, which is usually 1 to 3 years, you lose every single one of those things in exactly the order that we just talked about. First, trouble with hair and teeth, and you need to hear reminders, and then you need prompts, and then we have to actually put the toothbrush with the toothpaste in your hand. Yeah. And then dressing, and we're helping you a little bit in reminders, and we're checking to make sure you're clean, and then we're actually helping you get dressed sometimes, or taking away and hiding the dirty clothes, and then we're actually dressing you. The toilet training, you're incontinent of bladder at night, and then you're incontinent of bladder in the day, and then you start having stool accidents, and then you're incontinent of stool, and you hate that, and you know that. But later in the game, you're incontinent of stool, and you don't even know that you're incontinent. Yeah. Talking, your sentences get shorter and shorter, you understand less and less. Good question for somebody in this middle stage is, what's the longest sentence that they can say? And the sentences get shorter and shorter. And then we're only one word. Can they even express their needs in a word? No. You have to figure it out non-verbally. So now we're from middle dementia into late dementia. The watershed there is forgetting how to walk and talk and feed. And once you can no longer walk or talk or feed, not all three, the Alzheimer's people walk till late. The vascular dementia stop walking early or stop talking early, very early. So it's variable, but in general, as you're losing your walking and talking and feeding, you're moving into late dementia. And in late dementia, you're total care. You're usually chair-bound. You may be a mechanical lift transfer, or you can still weight bear. Again, you go from fully walking to only able to stand up. The baby could just pull up on the coffee table. These are our seniors who can do a one-person transfer. And then it's a two-person transfer. And then they can't even weight bear on their feet. But they can still fall out of bed and crawl out of bed and crawl around on the floor. And then they can't even crawl around on the floor anymore, and they're immobile in the bed. But they can still roll over and turn, and they don't get pressure sores. And in the late stages, they're so stuck and rigid and immobile that they can't even turn over in the bed. They can't even reach and pick up a cup. They've lost that motor control, and they're back at that baby stage. So they lose their talking exactly the same way as they learned it. They lose their feeding, and they go from knife and fork and spoon to just a spoon to just finger foods to spoon-fed to not even be able to do finger foods to forgetting what to do with food. They look at food and they don't recognize it. Agnosia. I don't know that that's food. Or they start eating houseplants. They think that that's food. They don't notice it. And then they start forgetting how to swallow. And they're cheeking, pouching, squirreling. They've got the food in the 20 minutes after lunch. There's still lunch there in their cheek. Or they chew and chew and chew. Or they just stir it around on the plate. And none of it ever actually gets in their mouth. They're just playing with their food. Yeah. Now we're into actively dying. In late dementia, you're sleeping more and more of the day. You know how babies in that first 3 months just ate and slept? That's late dementia. And in late dementia, you might be sleeping for 50% of the day. As you get closer to actively dying, that number goes up to 80% of the time. You're sleeping most of the day. We wake up for meals, and then you eat, and you're awake for meals, and then you're put back to bed. As you transition to actively dying, you're sleeping more and more. It's harder and harder to wake you. You're less and less interested in food. It's harder and harder to get you started. And then you start actively refusing food. You're turning away or refusing. You're pursing your lips. And when you're refusing food and sleeping 90% of the day and we can't wake you up for meals, now it's time to call the family. You should have called the family a long time sooner, actually, and have those conversations with them. And then at the very end, many people just forget how to swallow. Yeah. So that's the dementia trajectory. Now, I want you to get this piece of paper that I don't have on a slide, or if you like, this piece of paper. So this is the roadmap. And the story is that I was having exactly this conversation with so many families that I thought I should really write this down and save myself some time. And this dementia trajectory is mostly the same no matter what kind of dementia you have, and it's even the same for late frailty. With dementia, you forget how to dress yourself and groom, and then you forget how to manage in the bathroom, and then you forget how to walk, you forget how to talk, and then forget how to eat and feed yourself, and then you forget how to swallow, and you die. With late frailty, it's not that you forget, it's that you need more and more help with. So you can have these conversations with people who don't have dementia and just substitute forgetting how to with the words needing more help with. So in the trajectory, I divide the dementia process into the early process, middle, late, and actively dying. And for each stage, I talk about the patient and what they're experiencing and the signposts. We're likening this to a road. This is a road that you're going to travel, and I'm giving you a map of the road. Families need a map of the territory. They've never had a dad die of Alzheimer's disease before. You have seen this movie hundreds, for some of us here in the room, probably close to 1,000 times. And we know exactly what's coming and where things are leading to on this road. But families don't know this. and they freak out. When dad starts to fall, he's not walking safely, he's forgetting how to walk, they want us to investigate. They want us to do something. They want us to do tests. They want us to fix him. When he starts becoming incontinent, that's a problem. This is a huge problem. We have to do something about this. They panic. The only way we can support them to make appropriate choices is to give them a picture of the road from early on. This is where we are now. This is the normal disease process. This is where it's taking us. These are the things that might come in this next little while. These are the things we need to think about and talk about now and get you ready for them. And this is where we're eventually going. So across the very top of the trajectory, we start with early and middle and late. And right at the end there, at the top of every page, is actively dying. And from the very first time that you're handing this to a resident, you're giving them the clear message that this is the road we're walking, and the end of that road is actively dying. So this is the practitioner version, and it's got some more medical language and some more medical stuff about medications and stuff. And this is the family version with softer, gentler language and none of the medical stuff. And I encourage you to give these to families and walk through them. The signposts are the things that come along, like he's no longer weight-bearing. He's become wheelchair bound in the last month. That's a huge signpost. As we're doing that, that's a really good time to talk to families about this is what's changed in this last little while. It means that we're now entering perhaps the late dementia stage. Your dad is now in a wheelchair. He's needing more and more help with feeding. He's completely incontinent of bowel and bladder over this last 5 or 6 months. We're moving from his middle dementia into the late stages of dementia. And things are going to start moving faster now. In early dementia, that's typically 3 or 4 years. In middle dementia, that's probably 2 or 3 years. Late dementia is probably a year or a year and a half, sometimes shorter. Yeah. The process goes like this. And as you start changing faster, this place in the curve where we're starting to change faster, we really need to wake the families up. We need to say, we're at a stage where things are going to start moving faster. Your dad's moving into the later stages of his dementia. Things aren't going to change from year to year. They're going to change from month to month. And as we get closer to the end, they're going to change from week to week. And in his dying days, they'll change from day to day. The very best predictor of how fast things are going is how much has changed in this last little bit. And if you do a care conference and a year later, functional abilities, walking, dressing, feeding, talking, they're doing most of what they did last year, we've still got years. If you do a care conference and in the last 3 months, they've lost their walking, they're having trouble with feeding, and they're now total care, they've changed lots in the last 3 months, and we're in our last months. It might be 9 months or it might be 15 months, but it's not years anymore, it's months. And as you're approaching the end of life, he's really been refusing food over this last 3 or 4 weeks. It's harder and harder to feed him. And over the last 2 weeks, he's refusing food most of the time. We can still get the odd bit of ice cream in. And in this last week, it's harder and harder to feed him, and he's sleeping most of the time. Things have changed in the last weeks, and we've got weeks left to go. I don't say 2 weeks, I don't say 6 weeks, I say weeks, I say months. I'm always wrong as soon as I give a fixed thing. So I just leave it wide open. Years, months, weeks, good. And when we're at the very end, your dad hasn't drunk anything for 3 or 4 days now. We're in days. He's in his last days. Families get that. Yeah. So the conversations are, what's changed? Where are we now? You're in middle dementia. You're moving into late stage dementia. What's coming next? At each stage in the conversation, you need to tell the family, here's where we are, and this is where the road is taking us. Your dad is in middle stage dementia. I'm so glad to meet you, your dad. I hear that your dad is needing some support with dressing. He's feeding himself. He can still speak in full sentences. He's walking mostly safely, but there have been a couple of early falls. He's in the middle stage of his dementia. I'm guessing that over this next year, he's going to need more and more help with his walking and feeding and possibly his bowel and bladder. At some stage in this next year or so, he may start to become incontinent. That's a conversation. Another conversation. Your dad has really changed in this last couple of months. It's harder and harder to feed him. He's sleeping more and more. I don't think he recognizes you anymore. Does your dad still recognize you? No, my dad doesn't recognize me anymore. We're in the late stages of dementia. We've got months left. We're getting close to the end now. Your dad may be dying soon. The dying word. Yeah. So those are the signposts that we look for. When I find signposts, that's a great time to have a conversation with the family. In each of the stages, I've got a list of good questions. For the early dementia, it's how safe are they? And how much support do they need? And how are you coping? Are you burned out? In middle dementia, the good questions are, again, about function. What are you doing? In the feeding, dressing, bowel and bladder, walking, talking, eating. Where are we in that? How much are you able to do for yourself? And how much has changed? And how quickly is it changing? Because that'll tell us how close we're moving to the finish line. And the cognition. Is he able to find your room? Are you still able to? Is he able to still say your name? I know that he knows you, but can he say John? Can he express his needs in words or only non-verbally? So now in late dementia, the good questions are, what percentage of the day is he sleeping? And I just get the carers to add that up. Okay, between 7 or 8 o'clock in the morning and 7 or 8 o'clock at night, he's up for how long in the morning? And then you put in, okay, so he's up for 2 hours in the morning and then he's back in bed, okay. He's sleeping, yeah, okay. He's up for another hour at lunch. Does he get up for supper at all? No, he's too tired. Oh, okay, maybe he's awake for an hour. Okay, so he's awake for about 4 hours of the day? Yes, that's 4 hours out of 12. He's sleeping 2/3 of the day, is that about right? And the family say, yeah, that's about right. And 2 months later, he's sleeping about 80% of the day. He's only up for an hour in the morning, maybe in an hour at lunchtime. So that's only 2 hours out of 12, my math says. Yeah. 16, 15%. He's sleeping 80, 85% of the day? Yes. That's a very simple visual that the family gets. They hear 80% and they say, yeah, every time I come in, he's asleep. I try and wake him up and I can barely, I don't think he even knows me. They see the end coming when you put it in those terms. Yeah. How interested is he or she in food? A big predictor. If you still want to be here, and apple pie or ice cream arrives and you get that first taste and you go, and you're reaching for the spoon, that means I want to stay alive. I'm still interested. But when food comes along and we tempt you and we touch and pursing and turning your mouth away, that speaks volumes. It means I'm done. It means I don't want to be here anymore. I'm not having any fun. I'm ready to go. And family need to hear that. He's refusing food. I don't think he's having any fun. I think he's tired out. I think he's ready to go. He's getting ready to go. So that interest in food and the amount of sleeping is the single biggest thing. Does he still recognize you? Does he still know who you are? Can he still say your name? Yeah. At that stage, we need to start having the end-of-life conversations with family. Your dad, I think your dad is dying soon. I think he's in his last weeks. And that's a crucial conversation with family, because if we tell them that early, and we have all these other conversations beforehand, this will go well, and they won't panic. But if this is the very first time that we've had a conversation with them and nobody's ever said anything about dad dying, and we say the dying word, there's going to be an atomic explosion. They're going to melt down. They're going to panic. They're going to talk about going to the emergency department. We're going to have really silly feeding tube conversations. Yeah. So we need to have the conversations early and let them know at each stage what's coming on the road and anticipate those changes so that they can prepare emotionally. I don't know about you, but I have a slow heart. If I'm about to lose my job, or my marriage is ending, or something bad is going to happen to one of my kids, I need some time to get ready for that. If you give it to me all at once, it's going to go sideways. I'm not going to do very well. I'm not going to show up with my best self. You're likely to see my worst self, in fact. I need time and warning for me to digest emotionally. And I can put up with a whole bunch. I can handle a lot if you give me some time. Families are like that. They can cope with just about anything. They're extraordinarily resilient, but we need to give them some warning and give them a chance to do that anticipatory grieving. Yeah. So, on the back side of your dementia trajectory outline, is a conversation guide. That's this one. So these are simple conversations. This can take 3 minutes. What's changed? And at a multidisciplinary conference, I'll just get the care aides and family. I'll sit down, welcome everybody. This is a chance for us to review your mom's care, see if there's anything that we can do to make her more comfortable, see if there's anything that she hates that we can change and fix things up. Glad to see you. These are our medical issues. But first of all, I need to ask you guys as a family. I'm just going to read my notes from last year when we last spoke to you about all this. And my question for you is, what has changed in your mom's care? I see that last year she was still walking safely and doing most of her dressing and grooming for herself. She needed some reminders. She was mostly continent to bowel, but she was having urinary incontinence, especially at night. She wasn't walking very safely, and she was using the walker, and she had had a couple of falls. She was talking well and understanding things and could still find her room, and she was feeding herself a regular diet. What's changed since then? Oh my goodness, doctor. She's changed so much. And then the families start to tell you what they've seen. And then you go through systematically with the care aides in each of those functional domains. How are they doing with dressing and grooming? How are they doing with the bathroom? How are they doing with mobility? How are they doing with their feeding? And you hear what's changed. And that gives you the information that you need. That gathering is a sharing of information so that the family and the care aides can hear each other, because the family, in some cases, are experts. But in some cases, they haven't really seen mom or dad that often. And when we compare notes, we all, as a group, come to a collective understanding of how much mom has changed and how quickly that change has taken place. And that's a good time for the physicians in the room to say, I see that your mom is in the middle stages of dementia or getting close to the late stages of dementia. And then, if you're confident with this, you can anticipate some changes. Maybe not right away, but at the end of the care conference, at the beginning of the care conference, I say, and can we take 5 minutes at the end just to look and see what the future might hold for your mom? They say, okay. So they're primed for that. So we gather all this information at the end of the care conference. I say, okay, this is where we are on the road. These are some of the things that I think might be coming next. And I think over the next few months, or over the next year, over the next several weeks, and I anticipate the changes, and we get them ready for what's coming next. That's, in a summary, the whole approach. This is the road. This is where you are. This is where it's going, and this is what's coming next. These are some of the things that we might need to decide about. Yeah, at each stage. What questions do you guys have about that? How is this landing with you? What do you think? Microphone, go for it.
I was just going to say, thank you very much for giving it some structure in a way, because it gives you an approach, and that's great. I have a very, very specific question.
Sure.
What do you do with your demented patients about pneumovax and flu shots? In Victoria, with every with every end of life admission, we are asked, is the pneumovax up to date, and if not, can they have it? And we are asked, everybody has to have a creatinine because they have to have their flu shot, and we're asked to sign orders for Tamiflu. I'm incredibly uncomfortable with all of those, and I'm really confused that we seem to be able to choose not to give people antibiotics, but we don't seem to be able to choose to not immunize people or give them Tamiflu. And I just wonder what your thoughts are on that.
I'm just checking, have the people in room 160 heard the question, or do I need to repeat it?
Is it on?
Was your light on your microphone?
Yeah, it's really...
Is there a green light on there?
There is a green light.
No, I don't think it's on.
Oh, no, my
really
green
bright.
light's not on.
Okay, so for the benefit of the people in room 160, the question was, what about Tamiflu and pneumovax if these palliative residents are in the late stages of their life and we can choose not to give them antibiotics and comfort measures? Why are we obliged to give them Tamiflu and the flu vaccination? And pneumovax. So in the days when our length of stay was longer, this was a reasonable thing. There are younger so there's 10% of the population that is not old and doesn't have dementia and is not medically frail. That's the special populations, and they have neurodegenerative disorders, acquired brain injury, mental health and substance use issues. They're younger. So our medical health officer says, "Thou shalt," and I've had more than one conversation with him about the palliative nature of our world, and he says, but there are populations in there that require protection, and if the herd is not immune, then those individuals are at risk, and we need to provide herd immunity. And your resident might not benefit from this, but if the whole facility is like this, then there won't be an outbreak in your building, and frail, vulnerable residents will be protected. And I still don't buy it, and I hate Tamiflu, and I don't want to use this. The Pneumovax, if you're young in the sense of long-term care young, you might live another 3 or 4 years and not 6 months. The Pneumovax, if you haven't had it, might be useful for you. Depends on quality of life. All these goals of care conversations are predicated on quality of life. And I love to have the conversation with the family, with Dad there, and turn to Dad and say, "So, John, are you having any fun?" John's surprised. He stops and thinks. And some of the time he'll say, "Yeah, they got good food around here. There's some good-looking women in this building. I like it here. Oh, there's young women coming around." I said, "Yeah." So John still wants to be here. Most of the time, John's not able to answer, and the family says, "John's not been having a good time. John's not had any fun for a year or two now." He always said, the sooner this is over, the better. If I ever get like this, take me out behind the barn and shoot me. That's 80% of families. And with that clear understanding, then I say, the medical health officer wants us to give you a flu shot. It's fine with me if you decline. I don't think it's useful for your father, and they can choose to decline and sign off on that. And that's a conversation that now, over this last year, I'm having fairly consistently, if not at admission and at the first care conference, then at the start of flu season. I can't have a conversation with 92 families, but I'm trying to have it more often, and the nurses are empowered to ask, "Do you want your dad to have the flu shot or not? I think he would benefit, or I don't think it's of much use for him." And if the family decline, then we're free not to do those things. Yeah, I'm not a believer.
So it's about having the family decline rather than
we're
the
obliged.
public health officer can accept it.
We're obliged.
Because of consent.
If the family says no, thank you, we don't have to do that. Yes. Other questions about having this conversation with families? Care age shouldn't. Yes, please. Oh, please. Yeah. Microphone on. Is there a green light?
This one works. Seems to hear it. I think it's on now. Is it? Can you hear me? It's going on and off.
Oh, good.
The question I had was, its gain goes with quality of life, is cannabis. We're getting asked constantly about cannabis now.
Mm-hmm. Being from Nelson, you're getting... So... I think I've convinced a number of my long-term care colleagues that marijuana is actually really useful in some cases of behavioral challenges, behavioral and psychological symptoms of dementia, aggression, agitation. So if you're anxious and restless, motor restlessness and anxiety, you're driven by your anxiety, then sometimes we can use marijuana to good effect. The way the licensing regulations are, although it's legal, unless I can prescribe it and it's got a DIN number on it and my pharmacy can provide it and the nurses can touch it, it has to be given by families. So if it's cannabis oil, the families can come and they can administer it. I have no idea what the strength is. The family doesn't want to come 3 times a day. They might come twice a week. It means that if you're managing a challenging behavior, it's difficult that way. But I can prescribe Nabilone or Sesamet, 2 brand names of synthetic THC. It's not got any of the CBDs in it. It's pure THC. It's not nearly as effective as the oils, but it works about a quarter of the time. If you're looking for treatment of insomnia, restlessness, anxiety, the worried motor restlessness, agitation of dementia. It can be helpful. Pain, yeah, okay, won't hurt, might help. Some residents don't like the way it makes them feel. They don't like to feel stoned. It's a useful tool in the toolbox, and I'm happy to use it. It's difficult for that 10% of the population who are younger, who are more capable, who are mobile, and have got mental health and substance use issues, who want to smoke it right at the front door. Yeah, and we tell them that they can't do that, and they tell us to go put it where the sun doesn't shine. Yeah, so it can be a challenge to manage in the facility. You have to have a locked box. The patient has to be able to self-administer. They can't have it anywhere where another resident can reach it. They don't have to have nurses involved. They have to be able to self-administer. So that's a small segment of the population, unless family want to help administer it for them. So this is a complicated answer. It's a nuanced thing. What else? A question about Ritalin for apathy and frontotemporal dementia.
I think if you touch the base of your microphone, or the screen microphone.
I don't think they're working.
No.
I'm sorry. Yeah, it's on.
I think it's on now. Oh, it's flashing.
Okay, flashing means it's working. Okay, so the question is frontotemporal dementia, apathy variant, and Ritalin. Okay, worth a try. So who are we treating? Is the resident having any fun, or is the resident miserable? If this is a comfort measure for the resident and their quality of life is better on this, and they're more motivated and they're doing more for themselves and they're experiencing pleasurable activities, then maybe life would be better on this stuff. I'm sensitive to coffee myself, and when I've had 2 cups of coffee and I start vibrating and nauseous and sweating, that's what Ritalin does. So I'd be careful. We need to make sure that it's actually helping, and then again find the sweet spot and adjust it so that it's... What's your experience? Has it helped your resident?
Usually in a younger population. A bit of a younger population.
In the...
I have a man that's he's just sitting in the room. He's quite apathetic.
Mm-hmm. Is he having any fun? Okay. So we could try the Ritalin, start low, go slow, and if his quality of life is better, great, good thing. Turn up the dose until his quality of life gets better, or you get side effects. And if there's just side effects and no improvement in quality of life, I guess that's our answer. I'm willing to try anything, and I'm careful to titrate the dose. We're looking for the sweet spot. And if that helps for him, that's great. I've seen patients come in on it, but when they were functioning in community, their function level was higher. It might have been useful for them, but by the time I get them, they're on a big bag of pills and their quality of life is really poor and they've got advanced dementia. I just stop most of the pills. That's a huge thing that you guys as physicians can do, is to stop all the pills. Not all of them, but just turn them down. The pill burden, I don't know about you, but when I take medications, I get a sick stomach and yucky. 60% of our residents are on 40 or more, or on 9 or more medications a day in some facilities. The average across my health authority is 45% of residents are on more than 9 different medications a day. That's not pills, that's medications, and each medication may have 2 pills 3 times a day. So if this is breakfast, that is so nauseating. So in terms of quality of life, simplify the medications. Strip it down to the basics. Stop most of the preventive medications. If you're not sure about a medication, try cutting the dose in half until the nurses reduce Lasix from 40 to 20. Watch for shortness of breath, increased leg swelling, weight gain. And it's amazing. Patients get put on Lasix. They have acute pulmonary edema. And 3 years ago, and they get 60 of Lasix a day, and they're on 60 of Lasix a day for the next 3 years, and nobody's ever changed it. 80% of the patients on Lasix who come in my door, I get off of Lasix successfully in the first 3 or 4 months. Risperdal, the same thing. You had one psychotic episode where you punched a nurse and you're on 3 milligrams a day of Risperdal for the next 2 years, and nobody will touch it. Best practice with all antipsychotics is that as soon as the patient's target symptoms are stable, you try reducing the dose slowly. And you keep trying to reduce it slowly until their symptoms come back or they're taken off of it. Dementia is a fluctuating illness. You go through a period of very challenging behaviors, and then into a calmer period afterwards. And that difficult period doesn't mean that you have to be on Risperdal for the rest of your life. We're looking for the sweet spot, and as soon as you've been stable for more than 3 months, I'm going to try and turn your dose down by 1/4 milligram, from 1.0 a day to 0.75 a day, and reassess in 2 weeks. And the nurses all say, don't. And I say, yeah, sorry. And it works. And it's so much better for the residents. Hello. Yep.
I just wanted to say, in your experience, have you noticed, like, when we found some people that we feel are heading into the dying zone, we've wanted to get palliative orders for these people. And once we've cut them off of their oral medications, because they're not swallowing anymore and all that kind of stuff, in some cases we've found that they've rallied, and all of a sudden it's like 8 months later they're still with us. And I just wonder if you've experienced that in your settings.
Yep, absolutely. I can think of I won't say the lady's name, but she was in advanced renal failure, end-stage congestive heart failure, a list of pills this long, and she was on significant doses of hydromorphone for significant pain. And she had been totally bedbound in mechanical lift transfer for the entire 2 years that she'd been in our care. And she became palliative and stopped eating and drinking, and we stopped all of her pills. And 4 days later, the nurse was in the med room in the middle of the night, 2 o'clock in the morning. And like every good nurse, she had heard footsteps behind her. And being a good nurse, she knew who it was because she knows the footsteps of everybody in the building, and she couldn't figure out who was behind her. And she had to come out of the bedroom and look, and here was Faye coming down the hallway. She wasn't dying, she was up walking for the first time in 2 years because we had stopped all her pills. That's Faye, yeah, absolutely. Sometimes they're dying, and sometimes we're just giving them too much of the opiates, and we need to cut back on the pills. Find the sweet spot. Don't be afraid to turn down. Don't always turn up. Just try turning down. Yeah. Okay. We're going to take a break for 10. Okay.
I only do residential care, and in my patient population, I have 21 patients over 100. 17 of them are women.
Yeah.
4 men. And the fascinating thing is that if you look at these people, they're the patients with the least number of medications. And I find that quite fascinating. My lady's 106, she's going to be 107. She took a Tylenol at bedtime, and she said it was a sleeping pill, and I wasn't going to argue with her. What was fascinating, her son was 86. And when he came in, she tried to mother him because he was in worse shape than his mother. So it's just fascinating. Very few pills in my older patients. So, in a way, it made me think as physicians, what are we doing? We're actually killing patients with our pills.
I've got a study that will show that. Darwin Garfinkel did a study where he was on nursing wards, and in one group of patients he kept them on all their pills, and another group of age and disease-matched cohort cut their pills in half. And at the end of a year, the mortality rate in the people who hadn't cut the pills was 35%, and the group that had cut their medications in half was 12%. He cut their, yeah. Okay, let's take a break for 10 minutes and then come back because I want to talk to you about difficult families and conflict. 25-2, we're coming back at 25-2. Oh, that I couldn't see.
Yeah, so I tested it before, but I'm not sure why it's not coming.
Oh, I'm sorry about that. Yeah. There are some chairs here that you can... I'm sorry, my microphone. There are some chairs here if people want to move over. I apologize. Okay, we're going to get started. Yes?
People in the other room that were having some questions.
Oh, I'm really sorry.
So we can just remind them that anytime they ask a question, they have to turn off their mic or no one else will be able to ask a question.
Right, okay.
That's why it's
Can we turn the temperature down in the room? People are melting at the back. Yeah, I think it's quite hot in here. Okay. Everything's going fine. I'm running out of time. I'm talking too much. I'm running out of time.
do you mind if I share your presentation after this?
Absolutely, that's fine.
I'll send out all of the lecture materials.
Thanks. Okay, folks, we're going to start. Ding, ding, ding. I'm going to start talking about unhappy families. Yeah.
George, miss seeing you, man.
Okay, folks, I'm going to start talking. I want to talk about train wrecks.
Hey, room splitting. Stephen,
And you're going to say, Dr. Janz, what do you mean by a train wreck? And I think we're all going to be pretty clear about what a train wreck looks like. I don't have any disclosures of conflicts of interest. I'd love it if there was a drug company that we could find something to give to family members. Yeah. Can't hear me again. Okay. Have I got a... It's on. Can you hear me now? Okay, better. Okay. So, thank you for pointing that out. I hope that room 160 can hear me adequately. People in room 160, I apologize. I hear that there were questions there that didn't get to us. There are 5 or 6 or 8 empty chairs here if you want to join us in this room. And I'm going to ask you for questions and let you guys speak first. It turns out that if somebody else's microphone is flashing green, nobody else's microphone works. So when you finish speaking, turn off your microphone so that it's not flashing green anymore so that the next person can ask a question. And I'll try and remind you, you can keep us honest. So we're going to talk about family dysfunction and team conflict. And when we're done, I'd like you to be able to recognize a bad story as it walks through the door. I'd like you to be able to figure out risk factors for team and family conflict. I'd like to give you some tools that you can use for each of those risk factors. And I'd like you, when we're done, to feel a little more comfortable with managing team and family conflict. Because I think this is the single most uncomfortable piece of residential care for most nurses and doctors, is the family that's melting down all over us. Yeah. Crazy families. So what do I mean by a train wreck? Train wrecks have high emotional intensity. When everybody's on the roof, when everybody's really angry or frustrated, when you come onto the ward and everybody starts telling you all about Mrs. Jones and Mrs. Jones's daughter. Yeah. There's interpersonal conflict not just between staff and the resident family, but between staff members now, because we're fighting with each other. Yeah. And at a personal level, you know that you've got a train wreck when you go onto the ward, doctors, and 3 different nurses come to you and say, Mrs. Jones's daughter here, and she wants to see you right away. And your stomach goes, ooh, oh, that personal sense of dread, the reluctance. And I'm afraid I'm afraid that I'm not going to meet their expectations. I'm afraid that they're going to ask me to do something that I really don't want to do. I'm afraid that we're going to have a bad outcome, that I'm going to get sued maybe. Yeah. I'm trying not to see Mrs. Jones's daughter. I'm hoping I can get out of the building before she catches me. Yeah. So now I'm losing my boundaries. I've got unhealthy boundaries. So sometimes I'm drawn in and I want to do way too much for a family, and I've got no boundary. I want to do it all. And other times the family member pushes my buttons and I get angry and defensive, and my soft, flexible, reasonable boundary becomes an impenetrable brick wall, and I become rigid and uncompromising and black and white. And that's not very healthy. My healthy boundaries are messed up. And then staff start avoiding the family member, and they don't want to deal with them either. They hide when the daughter comes, which leads the daughter to say, "No one is caring for my mum." And the other piece of this is that if nobody's having a conversation with daughter because they know that they're going to get a huge earful of unhappiness and bile and blame and name-calling and maybe even some shouting, so let's not go do that conversation, then no conversations are happening and things get way worse instead of better. And when the conversations stop, then the misunderstandings only get bigger. Yeah. So the workplace environment starts to get energized. More and more frustration, more and more anger. We're not talking to each other anymore. And we start to live in different worlds. And the family believes this and insists that the team is doing all sorts of malicious things. And we start misinterpreting each other. We start misinterpreting comments. We take people's intentions the wrong way. People get energized and we stop listening to each other, but we keep talking at each other. And we get into hardened positions. I'm saying the same thing to you over and over again, and you're not hearing me, and you're saying the same thing louder and louder to me, and I don't want to hear you. And we get hardened into our positions, and we, not surprisingly, the family loses trust in the team. I can't trust you. I need to watch every single thing you do. I need to watch everything you say. You're lying. I know that this happened, and you say that it didn't happen or that it's not the way it was. No. There's lying, hiding, distorting the truth. And then we get to a situation where family is caring for dad in spite of us, not with our help, but in spite of us. And then staff start calling in sick. And casuals don't want to work in Diamond Cottage. And no casuals will fill the shift, so now we're working shorthanded. And the family sense that you're understaffed and no care is provided for my mother are right. Because there's only one care aide instead of two in a cottage with 18 residents, and they're run off their feet, and they're terrified to meet daughter, and every time they meet daughter, they have 20 minutes of a tirade and blame and anger and shouting. And now we're really in trouble because the person doesn't call in sick anymore. They quit their line and move to another cottage, and no staff member will take that line in Diamond Cottage. And now we're chronically understaffed, and we have a real problem. Yeah. So now we've got a toxic environment. And in a toxic environment, everybody starts behaving badly and bad things happen. Staff start behaving unprofessionally. They're hiding or mischarting incidents. Stuff that happened never makes it into the chart. They're scapegoating other staff for shifts. He got bed sores because nights never turns him. They start speaking inappropriately to the family. Your dad needs medication. These kind of behaviors, we can't handle these behaviors here. He shouldn't be here. He should be moved to another building. We're understaffed. We can't handle this. These are not things you should ever say to a family. These are things you say to your supervisor. Yes, you may be understaffed, but you tell your supervisor, you don't tell the family. And then the family starts misbehaving in this toxic environment. And they're abusing the care staff, like literally abusing the care staff, and firing some caregivers. I will never let Donna provide care to my mom. I don't care what your shift says. Donna will never touch my mom again. Yeah, that kind of stuff, the scapegoating. And then the family starts sabotaging the care plan. Yeah. I'm just going to put in a word to administrators and physicians that our staff can be abused by families sometimes. And it doesn't happen to men, doctors, powerful people who show up. They shout at me a little bit, but not too much. But I'm a doctor and I'm an authority figure. Can you?
Shout at women doctors.
They shout at women doctors. But can you imagine a female care worker working nights alone in the cottage, and maybe she's an immigrant from a different culture with different colored skin? There are bad things that happen in we have to protect our care staff. It's our job as an institution not to let this happen. And we, the people who've got the authority, you, the care coordinators, you, the nurse managers, we, the doctors, need to protect our staff. We need to have clear boundaries around family behavior. Yeah. We can't let this happen in our building. It's not okay for residents to hurt each other. It's not okay for families to hurt our staff. Residents hurt our staff all the time, and we have to do our best to protect them against that. But family members have no excuse. They're not allowed to abuse us, and we have to protect our staff. So, yeah. So now we start getting into really deep trouble. Family are denying or avoiding medical facts. Yeah. You need to get my dad walking again. Are you kidding? Your dad hasn't walked for 6 months. He can't even stand up. This just doesn't make sense. He shouldn't be getting weaker like this. You're not feeding him. If you fed him properly, he'd be getting stronger. My mom's losing weight because nobody's feeding her. She's getting neglected. So this family are blaming us for the resident's decline. It's your fault that he is. This is a problem. And then families start demanding stuff. They demand the full names of staff. They start secretly videotaping or recording conversations. Hands up those of you who've had a family member who wanted to videotape her. Yes, yeah. They start soliciting complaints. Has that carriage George abused your mother too? Anybody ever heard this? Not yet? Yeah, they start, yes, hands. And then the threats. I'm going to report you to the college, the lawyers, the newspaper, the seniors ombudsman, hands up, yes. Have any of you actually been reported to the seniors ombudsman? Yes. Mm-hmm. And then critical incidents. And the critical incident can be the thing that started all this, and then we go to hell in a handbasket after that. Or we can be in a toxic culture, and it's the toxic culture that actually causes the critical incident. Yeah. So the resident-to-resident aggression. I had a dear lady who was full of piss and vinegar. And Frank has got late middle-stage dementia, but he's got a strong grasp reflex, and he wanders around, and anything that he gets hold of, he grabs and starts moving at tables, counters. He pulled off our kitchen island. He started tearing off the baseboards. He's taken the fire alarms off of the wall. If he can grab it, he pulls on it. And Jean, dear Jean, full of piss and vinegar, can't leave anybody alone, and she's right in your face, and she's talking at you, and Jean gets right in Frank's face, and Frank does what he does best, and he grabs her. And then she loses her balance and goes down. Family were really upset. Jean lives 3 doors down from Frank. And 3 weeks later, despite her best attempts, she fell down again. And nobody saw either of these incidents. Frank was there, and Jean was there, and Jean was on the floor, and Frank was standing there. We have no idea what happened, but family members went ballistic about this one. They wanted Frank tied up. They wanted him medicated. They wanted him full of drugs. They wanted him moved to another facility. They wanted him locked up. They wanted him restrained. They wouldn't take no for an answer. They were furious about this. Yeah. And if you had a resident-to-resident aggression that resulted in a fall, that resulted in a fracture, that resulted in a death, fracture and then death, fell and they died, yeah. Yeah. I had 3 hip fractures that resulted in a death 1 year, and 2 of them were resident-to-resident aggression. And any of you had a coroner's inquest? Yes? 1 or 2? Yeah. Have any of you had a code white with a resident or staff injury? Yeah.
What's a
a violent incident where all the staff are called to try and respond appropriately to the emergency. Have any of you had an unexplained resident injury? I'm going to explain. Yeah. So, lady who's bedbound, late dementia, Schilder's disease, rare kind of dementia, blind and demented. She and her brother both had it. Brother died years ago. She's been in the building for 20 years. She was in 2 different care homes before this one. She's been bedbound and a lift transfer. She can't fall without us knowing about it. She's a mechanical lift transfer. She can't even roll over in the bed. And then she developed some pain in her leg. And 3 days later, I'm finally called to see her, and she's got an obvious femoral fracture. She can't even roll over in the bed. How did she get a femoral fracture? Nobody's talking. There's nothing charted. Somebody had an accident with a lift. Something happened. I don't know what happened. Staff were interviewed. We did one-on-one interviews with each of the staff members. We suspected night shift. There was massive suspicion inside the care team. Somebody's lying. Somebody's done something to dear Dora, and no one's willing to admit it. It went on for 4 months. Yeah, the BC Patient Safety Office was involved, did one-on-one recorded interviews with the night staff, with everyone that was involved. We never figured it out. No answer to that. 2 years later, the other hip is broken. And yeah, what's going on here? And this time, because the coroner's inquest, the hip was obvious, the femur was obviously broken. I didn't even send her to hospital. It was obvious it was broken. We sent her to hospital this time. The x-ray was fascinating. It showed that she had bones made out of potato chips. This was a pathological fracture. Nobody had had an accident with her. She'd been rolled over in bed. Nobody had done this to her. And Dora, interestingly, microphone.
Is it going to work? Okay, there we go, it's working. I actually had a fracture, hip fracture similar to that. I was actually caring for a young one who was 16, bedbound, delayed due to a brain injury. And what we finally realized was this simply, again, they're losing bone density because they're not moving. And simply that act of pulling the lift sling underneath the thigh is enough to just create enough torsion to cause that fracture.
Wow. So just as it happens, I'm away from my home facility for this last 3 days here in Victoria, and they phone me and Dora's got another fracture. Yeah. So skin breakdown, not communicated well to family. So hands up if you've had an incident like this where, yeah? So sacral ulcer, nobody knows anything about it, and it's getting deeper and deeper, and then all of a sudden we get this report of a sacral ulcer, and it's down to bone, and it's tunneling, and all of a sudden over 3 days it opens up to a hole this big, and nobody's talked to family about it. You try making that phone call. Yeah, that's a really hard one. We had a staff member who was stealing. She had a substance use disorder, and wedding rings, diamond wedding rings, were gone from the 3 cottages that she worked in, and cash from residents' wallets that they shouldn't have, but one resident, who was a higher functioning resident, lost cash and a number of necklaces. Oh, incidents like this create so much distrust and disharmony among the staff and suspicion. It's really messes up the team. So for all of these critical triggering incidents, interestingly, what does the most damage is not the incident itself. It's how you guys handle it. To the extent that you do early notification and full disclosure, no matter how painful, and you do your best to be transparent about it, and you acknowledge the gaps, and do real care planning and quality improvement to try and prevent them from happening again, and follow up with the family over the long term, this can make you look terrible if you don't do this right, or it can make it look better. We had a critical incident with it around toileting with a family member, and a year later at the care conference, the daughter said, "Yeah, that was really hard what happened to my mum. I was really upset. But you guys did such a good job of working on it and keeping me in the loop that I feel so much better now." She had more trust in us rather than less because we had done the right things. So with all this train wreck descriptions, I'm going to tell you, there are risk factors we can predict when this is going to happen. Some of these risk factors we're stuck with and we get absolutely no choice about. Some are modifiable and we can manage them a little bit. Some are entirely our own fault. And it deserves us right that we didn't do this. And they're additive. The more risk factors you have, the bigger the train wreck is going to be. If you've got one risk factor, you can probably manage it. If you've got 5 risk factors, this is going to be the perfect storm. Yeah. All of these we can make a difference for if we approach them proactively. So the first one, a bad medical diagnosis. There are some diseases that are just not very much fun. If you watch somebody with ALS or MS or Parkinson's disease die, it can be a rocky road. Their swallowing gets slower and slower. They're choking more and more often. They've got less and less ability to cough. Eating takes forever. You modify the textures. They're constantly aspirating. There's more and more mucus coming out. They're more and more chesty. They're more and more short of breath. They're starving. They want to eat, but when they eat, they suffer. Yeah, this can be a hard one. The really severe dementias with the terrible behavioral challenges, the aggression, sexually appropriate behavior, especially if it's a man predating on women, the staff melt down, families melt down. These are hard. And then there's that 10% of the population that's not old or demented and doesn't have medical frailty. They've got a mental health or substance use diagnosis, or they've got an acquired brain injury, and they're younger, and they're way more capable, and they're quite capable of going downtown and getting some of the substance of choice and bringing it back and hiding it just outside the grounds. And they're quite capable of standing right outside the door and smoking their joint no matter what you say or do. Yeah, those clients are way more capable in our building. We're a round hole and they are a square peg. They've been fired from everywhere else. Every other living situation in the community's been exhausted. We in residential care are a repository. We're the last stop for the unhousable. The buck stops here. They belong to us because they don't fit anywhere else. And those are a recipe for unhappiness. Uncertain course or prognosis. If you've had a big fat intracerebral hemorrhage and you're in a coma, well, you're going to die. That's all there is to it. It's the ones that you don't know whether you're going to die or not that can lead to trouble with families. So this is late-stage congestive heart failure. You could die tonight or you could still be here in 3 years. And the next time you got shortness of breath and chest pain, should we admit you to the ICU and do IV pressors and Lasix and dobutamine and assisted ventilation? Or should we make you comfortable here? And the family, when they hear that, often want us to do something. A stroke with partial loss of swallowing. I think I'll tell you about Franz. I think I've got enough time. Yeah, Franz. Delightful 86-year-old Dutchman. Vascular dementia. Sweet man. Gradually failing. And then he had a big fat stroke. Ooh, terrible stroke. Looked like he was dying. Not eating, not drinking, barely responsive, unable to talk to us. And the family, we had the big conversation. Franz is dying. Yes, he's dying. Oh, that's terrible. Yeah. A week later, he still wasn't dead. And wife and daughter, who were so devoted, were just not going to let him go. They were spooning teaspoons of pudding, of yogurt, of anything into Franz. And Franz was coughing and choking and aspirating and miserable. But they just couldn't bear to let him go, and he hung on. And 2 weeks in, he was still sleeping 90% of the day and barely awake. And they were still spooning things in, and he was still coughing and choking. And the family melted down. They said, "You're letting Franz starve. You are starving our dad. You're killing him. Of course he's dying of dehydration. Of course he's getting weaker. You haven't fed him for 2 weeks. We have to get an IV." At that point, I was called in as a clinical ethics. I do our clinical ethics committee in the Kootenay Boundary, and I was dragged in as the clinical ethics chair to do an ethics consult. Long conversation with the family, wound up with an IV for a week. After a week of IV therapy, he wasn't changed at all. He was still sleeping 90% of the day, still spooning in, still coughing, choking, all that stuff. But when I talked to the nurses, they would say, Franz hasn't eaten in 4 days. He's not taken a thing. And then I go in and talk to wife and daughter, and they say, he took a really good breakfast. We put a whole bunch of yogurt into him. And there's yogurt all over him. I don't know how much was inside him. But the family's perception was that we just needed to feed him more. And they were so attached to that. Yeah, that's a hard story. He did die a week later in the end, and it was okay. But those ones where we don't know whether we should pull out all the stops and do a whole bunch of interventions or make them comfortable, those are the ones that are the hardest. So here's a big one. Severe frailty. What do you mean she's dying? She's only 92. Her mother lived to 98. Leg organ failure, CHF and COPD. They got an ejection fraction of a wet paper bag. They've been in the emergency department 3 times in the last 6 months for severe shortness of breath. They've been to the ICU twice. Late COPD, they've got an FEV1 lung function of less than 30%. They've been on home oxygen for 3 years. They got short of breath, sitting on the couch. They've got severe cachexia, they're wasting. They've got a BMI of 21. They're scrawny, skinny little, because they're using all their energy to fight to breathe. They've been in the emergency department 3 or 4 times in the last year. And you say to the family, your dad's getting ready to die of a COPD. We didn't see this coming. Nobody ever told us it was this bad. What do you mean dying? Willful denial. Yeah. Late dementia. We're just not ready. You can't let my father die. We need a feeding tube. You're letting my father starve. Yeah. The unrealistic expectations of most of C1 or 2 in somebody with a late dementia. He always wanted everything done. Yeah. We have to do everything we can for him. Challenging family dynamics. Yeah. Denial and avoidance. The anger. I need the way mom is to be somebody's fault. I need somebody to blame because I feel so guilty about dad and so powerless and so afraid that I'm going to lose him that I need to manage that somehow. So I'm going to blame somebody else and not feel so guilty for not doing as much as I could have. The anger, these are primitive defense mechanisms. When I've got a very uncomfortable feeling, I'll do anything I can to manage or get rid of that feeling so I can blame or I can control. And we've all seen those family members who need to micromanage every aspect of their mom's care. Yeah. Their diet, their medications, their wound dressing, all that stuff. You can't give my mom morphine. I will not let you give my mom any morphine. But your mom is having pain. You're never going to give her morphine. Morphine will kill her. As soon as you give her morphine, she's going to die. Well, she is dying. No, she's not. Yeah. So the resident's not eating, and the family member says she's not eating because the staff are too busy to feed her. Mom's got a UTI. Of course she's got a bladder infection. You never give her anything to drink. The truth is she's got late dementia. She's refusing fluids. She's got a UTI. The pressure ulcer she's developing because she's no longer... An important piece of late dementia that I didn't tell you about is that your healing and your immune system shuts down in late dementia. You don't have the ability to heal wounds. And we actually talk about palliative wounds. When somebody's got open leg ulcers or a sacral ulcer that won't heal, it's because they're dying. Their serum protein level is so low that they can't heal anything. They scratch themselves and it doesn't heal for months. In late dementia, your immune system shuts down and you're more prone to bladder infections, chest infections, and skin infections, and you're more prone to unhealing wounds, and you're going to die with those wounds. They're palliative wounds. Your body is breaking down right in front of our eyes. Yeah. And those palliative wounds can be really difficult for families. Yeah. And my suggestion, what I'm going to propose to you guys, is that most of this is about unfinished business. Oh, my pointer doesn't work. This is about underlying family conflict. There's children whose parents were alcoholic or abusive way back in the past, and now that dad's dying, they're reliving that. There are power struggles between the siblings and unfinished stuff from when we were 6 and 8 years old. You're not the boss anymore. You always tried to take over and be the big shot. I'm in control now. I'm the power of attorney. I'll make the decisions around here. Imbalance of care, anger about workload. The family member who's been here all this time visiting and caring for mum, who's seen mum declining, who knows that she's really going and is ready to go. And then sister or brother, she's usually from the States. She's probably a... You're all going to laugh. She's probably a nurse, and if she's not a nurse, then she's a lawyer. Yeah. And the general tone of daughter from Texas is, I'm going to come in here and clean this town up. They've been neglecting my mom for long enough, and they need somebody like me to kick ass and raise a bunch of hell and get some action here. We're going to get her to the hospital. We're going to get a CT scan. Not a CT, I want an MRI, God damn it. Yeah, now. And the emotional tone here is, I'm going to throw my weight around and get angry and get something done to show how much I love my mother and how much I'm doing for her. Because I feel so guilty about being in Texas and not seeing her for the last 4 years, that I'm going to show that I'm really, look how much I care for my mom, and you haven't done anything. And the one who's been here all the time says, where the hell were you for the last 4 years? I've carried this all by myself, you jerk. Yeah. So. And then there's lack of a robust advanced care planning. Like, we never talked about it, or we did some advanced care planning, but it's wishy-washy and nobody really talked about what was going on. I've got this living will thing. A living will is an American document. It has no validity in Canada. And when we say no heroic measures, that tells me exactly nothing. Yeah. Nobody had a disease-specific conversation. Your dad has end-stage congestive heart failure. At the end, his lungs are going to fill up with fluid and his legs are going to fill up with fluid, and he's going to be so weak that he can't get off the couch. And then he's going to die. When that day comes, we'll know that we can't send him back to the ICU anymore because he's going to be so weak and his symptoms are going to be so bad that despite our best medical therapy, he's still going to get into trouble. Those kind of specific conversations about the next time your dad has an exacerbation of his COPD, I don't want to send him to the hospital. I've got oxygen here, we've got morphine, we've got nitrates, we've got Lasix. Even if he's not eating or drinking, by the way, you can give them subcutaneous Lasix if they've got late congestive failure and they're dying and their lungs are filling up. I would give them opiates for the shortness of breath, and if there's pulmonary edema, just give them 20 of Lasix subcutaneously. It works, it helps. As a comfort measure. Yeah. So just use the injectable Lasix. Have some injectable Lasix in your contingency medications and give it subcutaneously. Yeah. So we need disease conversations. And that's to get them ready. We've seen this coming for a long time, but unless we've had those conversations with the family, they don't know that dad being that short of breath sitting there in his chair means that he's got late congestive failure and that he's going to die soon. We need to tell them that and get them ready over and over again. Because if we don't tell them that, and they're not prepared, then when dad's dying, they melt down, they panic, they demand a whole bunch of things that are not a good idea for dad, and our chances of talking them out are pretty small. Now, poor communication. Sometimes it's our fault and we really didn't tell them. Sometimes it's family's fault and we've been telling them 8 times, and they still say, nobody ever told me that. Because they're not hearing us, their defenses are up. Sometimes it's between family members. We've been having a really good conversation with Sue at the last care conference, and then on the phone for another 20 minutes 2 months ago about your mom's changing condition. And Karen comes in, and she's not heard any of this, and she's madder than hell. And I say, didn't you talk to Sue? Do you guys ever talk to each other? No, in fact, they don't. Yeah. So just because we talk to one family member doesn't mean that we've covered all our bases. And then mixed messages. The nurses at the facility all said that mom was dying. Yeah. Well, I called her GP. He was horrified. He sent her straight to Emerge. I took her to Emerge. The Emerge nurses said they've never seen anybody so dehydrated in her life. And she was poopy in her diaper. They must be neglecting her. Yeah. Oh. Ow. We as a team need to do better than that. We need to talk to each other. The GP and the nursing team as families, high-risk families, if you've got risk factors and that patient starts to die, the GP and the care team need to be like this. And if you're not like this and you're not talking to each other, I guarantee it's going to go sideways. You and the care team, you really need to be on the same message, on the same page, very consistent messaging to the families. And if we do everything right, it'll only be a small train wreck. Yeah. And this one's all our fault. Poor communication within the team. Those bed sores you gave my mom from leaving her dirty in her bed and never changing her, she needs turning every 2 hours. We put it in the care plan. I told the night nurse, she didn't even know my mom had any bed sores. Oh, ow. Ouch. Busted. Pain and symptom control. My mom was in terrible pain all weekend. For 3 days, the nurses kept calling the doctor. The nurses said they couldn't give her anything until they got an order from the doctor. Could this happen in your building? Have you got contingency meds? Have you got nurse-initiated palliative orders? Now I'm going to give you a radical concept. In my buildings, the palliative orders are all written up, and I've got 5 or 6 signed copies in the med room. And the nurse initiates the palliative orders and gives me a phone call saying, I've initiated the palliative orders on Mrs. Jones. And the doctors say, wait a minute, you've got signed orders for all that morphine, and the nurse is going to start giving morphine without me knowing about it? I get a lot of pushback from doctors about this. But if doctors and nurses work together and trust each other and have that relationship with each other that says, I know that you know a good job. I know that you do a good job of this. You've got a senior nurse who knows what she's doing. You're not going to kill a patient with morphine on an order that's got my signature at the bottom of it. I can trust you, and that means that I can work with you and give you that leeway so that you're going to do the right thing at 2 o'clock in the morning, and you don't have to phone me. I would rather be sleeping, honest. And you can phone me in the morning and say, Mrs. Jones had a fall in the night. I'm pretty sure she's got a hip fracture. I'm pretty sure she's going to die from this. We've given her morphine. We're about to phone the family. I wanted, before I phoned the family, to say that I've spoken to the doctor and we've agreed that this is the best thing for your mom. Yeah. So if we can do a good job of this as a team, then we'll get away with it. And if we don't do a good job of this, we are going to look bad. Patients who've got uncontrolled symptoms, because our team can't get their act together, that's a problem. And when it comes to critical incidents, if we are a well-oiled machine, then we can do falls or send patients to emergency or deal with aggressive incidents, and it'll only be a small train wreck. But if we're not doing this right, any one of these could turn into a major catastrophe for us. We need to work out our policies and procedures, our processes, that we're doing a good job around medication orders so they don't get missed, so the pharmacy does send the medications before the weekend, so that things are working properly, so that abnormal lab stuff, diabetes, sugar's out of control, that we are doing a good job of controlling this, or we look so bad with families. So we need to have our house in order. Okay, so we're running out of time, and I wanted to save at least 10 minutes for questions and get you out. So I've got more that I want to talk about. I get you to vote. You can have as many votes as you like. I'm not sure how I'll do with room 160, but how many people, okay, pick your favorite risk factors. If you're going to have a train wreck and you had 2 or 3 things that you would think would be the worst. How many think a bad diagnosis, a terrible disease? Nobody. How about uncertain course or prognosis? 1 or 2. How about family denial or avoidance of medical facts? 3/4 of the room. Unrealistic family expectations. Everybody in the room. Challenging family dynamics. At least 2/3 of the room. Lack of advanced care planning. 1 or 2 or 3. Poor communication. Half the room at least. Poor team function. Oh, shame on us. Yeah, Okay. Well, how did I know that? Look what the next slide is. It's what you all voted on. Everybody always picks these. I don't know why that is. It's the anger, it's the blaming and the controlling. It's the family members who are melting down, who are quite unreasonable. Daughter is crazy. Yeah, we decide that. And the truth is that when your mother or father is dying, we go temporarily insane. Justifiable homicide. Yeah, we're temporarily not ourselves. Where's my paper? Yeah. So I'm going to propose that all of these emotional things... Oh, no. I'm missing a paper. There. All this stuff basically boils down to this. Yeah. What we're really dealing with here is unfinished emotional business and unmet emotional needs in family members. I'm going to start this conversation. I've only got 10 minutes left. I've got to hurry up. With our very basic emotional needs when we were infants, when we were small children. Because it makes a lot of sense when we're trying to figure out why we're behaving the way we do as adults, if we understand whether we got our basic needs met or not. And our basic needs are really simple. When we're really small, when we're that baby in arms, we need to be cuddled. We need to be fed. We need to be held safe. You are safe. All your needs are met. As young children, we need to be seen. We need to be recognized. You're separate from me. You're different from me, but I see you. I know who you are. I know what you like. I know what you're good at. I know the things that make you scared. I see what you need to be happy. As I see you. We need to be valued. You're precious. You're special. I see what you need. I see what where you're hurting. And I'm going to do something about that. I'm going to make sure that your needs get met because you matter to me. I value you. You're lovable. You're worthy. Very basic need. And then as we stretch out into the world, our young children, older children, teens, we need to be respected as an individual. Granted our independence, you are a capable individual. I trust you. You're good at stuff. You have the right to have your own opinions and think your own thoughts and make your own choices and be different from me. I respect you. You are capable. You are worthy. You are loved. Pretty simple, right? Many of our seniors who were at this stage 70 or 80 years ago, they'd finished the First World War. They were born in the dirty 30s, severe depression, or they were born during the Second World War, where they were in Europe, where there was starvation and violence and severe deprivation, or here, where there might not have been enough, there might have been poverty and hunger or displacement. Many, many of our residents, 70 to 80 years old, in their early childhood were traumatized. Their father came home from the Second World War with PTSD and depression and alcoholism. There was domestic violence in many houses. It was okay to beat children. Most children were spanked, many were beaten. My wife was beaten by her father. They may have had a rough time. And they were wounded parents. And wounded parents raise wounded children. And mom is dying. And her wounded children, in the worst case scenarios, as parents they may have been absent. They may have abandoned their children. They may have neglected them or been alcoholic or depressed, abused them verbally or physically. We don't know what happened in their home when they were young. probably these adult children that are caring for their mom and dad now might not have gotten enough of their basic emotional needs met when they were small. And now they're caring for a mom. And it's interesting how we can put all that under the carpet and live perfectly normal lives for 30 years and I'm really good, I'm okay. But now that mom or dad is dying, all that stuff rushes to the surface. And out it comes and it's not pretty. They might have been trying their whole lives to get these are the kids. This is the crazy daughter. Crazy daughter's been trying her whole life to get her basic emotional needs met, to get a little more nurtured, seen, acknowledged, understood, valued. But mom or dad's been wounded and for some reason wasn't able to give that. Yeah. They may not have been recognized or valued. You're stupid, lazy, you're worthless, and fat. They may not have been respected or granted their independence. You'll never amount to anything. You can't do anything right. You'll do as I say or I'll beat you. As adult children of wounded parents, daughter and others like her may now have their own addictions or depression or anxiety. Yeah. And now it's all coming to a head. And the most difficult, the most irrational family members are the ones with the most unmet needs. Yeah. And none of this makes any sense. The stuff that they're saying is not cognitive. It doesn't make logical sense. This is a feeling realm that we're talking about here. This is not frontal cortex, logical sense. This is limbic brain. This is emotional brain. This is I feel so, this or that. Many families, one of the parents was estranged, dad disappeared, or mom died, or something like that. Somebody abandoned somebody after some kind of a feud years and years and years ago. And now that somebody is now dying and is about to go away, all the abandonment issues come flooding up. And now I'm temporarily insane. Dad is dying and my emotional alarm bells around abandonment are going ding, 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 ding. And I'm in full sympathetic overdrive. I'm in fight or flight mode. And I'm not making sense. The white knuckles, the wide eyes, all of that. They get frantic. You can't let my mom die. That's a crazy phrase. That's not a frontal cortex speaking, that's a limbic brain. Yeah. One rather articulate daughter said to me, I wrote it down, I was so struck by it. I've been trying my whole life to get my mom to really see me. And now she's leaving, and I will never get what I've needed the most. 5 minutes, I've got 5 minutes. Yeah. What we really need to hear, even as adults, is really simple. You are so precious to me. I'm so proud of you. I love you so much. You really matter to me. A parent's dying has brought this old wound to a crisis. We can help. When you're faced with a family member who's melting down, who's not making sense, the emotional temperature is going up, first of all, notice it. Wow, things are heating up. And then stop and literally take a breath. This is not about me. This poor lady's mom is dying. And then go to the feeling realm. Don't talk. Don't take your frontal cortex out of here and go to the feeling realm. You're hurting so much. You're so angry and so scared. You're really not ready to lose mom yet. She's the only mom you've got. This is so hard. Just be there. Name the feelings. Let it be what it is. Be in the feeling realm with them. Don't argue with them. If you start arguing, you're going to have a bun fight. It's going to be awful. Yeah. So, name the feelings. Recognize their efforts. They need to be seen and respected and valued. I think you're doing a great job. You really care about your dad. You've worked so hard to make him comfortable. You've really showed up for your dad. Acknowledge them. Your dad is so lucky to have you. I see a lot of families. You've really shown up for your father. You've been here so much for him. I see you around the building so often. You make a huge difference to his quality of life. And then come around the table, and instead of face to face, come around and be beside them, and it's we. We can take care of your dad together. Let's do the best job we can saying goodbye to your dad. Yeah. Try and avoid the headbutting. Nobody wins. Yeah. But that takes a lot of courage from you guys. When daughter's coming at you with all guns blazing and wants it to be your fault, try to stay in your best self. So she's coming at you from her worst self. And we as healers have the opportunity to show up with our best self. But it's hard. Can we bring our compassion? Can we bring our empathy? Can we bring our gentle, loving heart to this poor soul who's saying goodbye to their parent? Pretty hard. Yeah. I've got some tips. I've got, that's the heart of the message that I wanted to deliver tonight. And I've got 8 risk factors with some concrete strategies for each risk factor. And I promised you that. May I beg your indulgence? 10 minutes? Yes, that's a yes. Okay, I'm off the hook, Emily. Okay, so our tasks. What are we going to do about each of these things? I'm going to go through this. If you've got a bad disease and you know right from admission that this is going to be a difficult one, let's start the conversation early. Give this family, okay, this is the road. The more often you talk about it and the more you help them do that anticipatory grieving, let their slow hearts warm up for this, you can minimize the damage. You can do damage control. At each milestone, each time there's a decline, have that conversation with them and how they'll know that the end is approaching. We'll know we're getting close to the end when he stops eating and drinking. He's less and less interested. Over and over again, reinforce, and we're going to make him comfortable. We're going to stay out of the hospital. The hospital is not a good place for your mom. Yeah. Emphasize. We do a better job at Jubilee Manor of heart attacks and strokes and pneumonia and bladder infections than the hospital. I'd like to keep your mum here for any of those things. I've got antibiotics, I've got morphine, I've got oxygen, I've got nitroglycerin. I've got a nurse here 24/7. We'll do a better job than the hospital for your mum. Let's keep her here. Have that conversation before you need to have the conversation. Have that conversation at the first care conference. And say it with confidence. And that means that doctors and nurses have to be functioning as a well-oiled machine so that you can actually do a better job than the hospital. Uncertain prognosis, explain. Mom or dad is frail enough that she could die tomorrow. I can speak in general terms. I can't say your mom is going to die in 2 weeks. I'm always wrong. But I can say people with this degree of congestive heart failure, about half of them will be gone at the end of the year.
Your call will be disconnected.
Thank you.